Hello, everyone. Welcome to another edition of Brain Trust, Conversations in Psychopharmacology. I'm Joe Goldberg, a clinical professor of psychiatry at the Icahn School of Medicine in Mount Sinai, New York. Here to welcome you as you join us for another opportunity to talk about issues that should be top of mind in clinical practice in psychopharmacology, things that we take for granted, questions that you always want to sort of scratch your head and say, I want to ask somebody about this. And we really try to focus on things that are very practical in importance and with colleagues in our field who really can speak with some definitive knowledge about things. So today, a real treat to have with us not to sound gushy, but a true icon in the world of clinical psychopharmacology, Dr. Carl Salzman. If you don't know of Dr. Salzman, he is a professor of psychiatry at Harvard Medical School in Boston. Did his medical degree at SUNY Upstate Medical Center in Syracuse, New York, followed by an internship in pediatrics at St. Luke's Hospital in New York, residency in psychiatry at Mass Mental in Boston, then a couple of years at NIMH, then back to Harvard, where he has since been quite an institution and a foundational fund of knowledge in so many areas in psychopharmacology. And so we're going to pick on a couple of particular topics that I think will play to Dr. Salzman's breadth of knowledge and expertise and experience. Hopefully questions that he hasn't been asked 100 million times over and is bored by them, but I think the things we want to talk about will be on the minds of many of us who practice in the field. So Carl, welcome to our program. Thanks for joining us today.
Okay, good morning. Glad to be here.
Glad to have you here. So our topic for today is around benzodiazepines and their misunderstood status, people's perceptions of them, the Beers criteria, get them off when they're over 65, the fears among so many clinicians out there that they're to be avoided. And I think I want to start just by asking, when inevitably you must be asked questions almost every day or thereabouts on that topic of, so are benzodiazepines all good or all typically respond to such initial questions?
Okay. We've had benzodiazepines since the 1960s. With Librium being the first of the drugs. They revolutionized the treatment of anxiety disorders. Prior to them, we had only barbiturates and Milltown type drugs, which were much more dangerous, had many side effects. And these drugs produced a reliable sense of relaxation, calmness, occasionally sedation, and very, very few side effects depending on dose. If you took a lot of them, they were sedating and could affect memory and people's balance, but those were in doses that were way above what was normally used. And for Librium, it was usually something like 10 milligrams 2 or 3 times a day. Because they were so novel, research began, and research has continued with the benzodiazepines right up to the present. So we really understand about these drugs very well from a pharmacologic point of view, as well as from a clinical point of view. And it's very clear from 60 years of experience that when appropriately used, these drugs are safe and effective. So I want to emphasize appropriately used, okay? The right drug for the right person at the right dose for the right period of time. Now that's a good clinical practice, basically, because that's what you would want to do for a patient anyway. But these drugs have not always been used that way, and they are sometimes overused. They're certainly misused, and they can be abused, and a part of an abuse. And I think we need to talk about all of those things. Now, the question of misuse is undefined, but I think most people think that that's taking the drug without a doctor's prescription. And so the question is, how many people take these drugs without a doctor's prescription? So I can answer that to some degree of accuracy, because there have been a number of surveys. The survey that I think the most interesting was done back in before the turn of the century, so it may be a little bit out of date now, but it was a door-to-door survey in a suburb of the San Francisco Bay Area. And the question was asked to the people who opened the door if they were willing to answer the question. The question was, have you taken one of these drugs even once in the past 12 months? And the answer was 11% of the people said at least once they had taken the drug. So that's a lot of people. Mm-hmm. The follow-up question was, have you taken it more than once? And the number dropped down to about 6% or 5.5%. Those numbers were compared with numbers from European countries, and it turned out that Americans were using benzodiazepines on this basis less than most other countries in Europe, except for Britain, which was less. Subsequent studies have found that the numbers are still more or less the same. That is, roughly about 10% of people have taken a benzodiazepine on occasion, and about 5 or 6% take them on a regular basis prescribed. Now, is that good or bad? I mean, that depends on how you see the world. If this prescribed use is effective and helpful to people, then that's very good, because the drugs are, when taken in therapeutically prescribed doses, these drugs are remarkably safe, and I'll come back to that in a minute. So, what about the additional people who take them without prescription? Well, what do they take them for? So I think as clinicians, we know that many, many people, psychiatrists included, have benzodiazepines in their medical chest at home, or take them when they travel. So, for example, many years ago at the American Psychiatric Association meeting, I was giving a talk on benzodiazepines. And it was one of those meetings where the audience had a button so they could answer a question. And I said to the audience, there were about 500 people in the room, big, and he said, how many people in this room have brought with them to this meeting a benzodiazepine, even if you don't plan to take it? And it's just, you can answer anonymously, so don't worry about it. So just push the button, yes or no. So what do you think we had? 1/3 of the people in the room said they had taken they brought a benzodiazepine with them. So then the question is, why? What are they taking it for? Well, most people would say to help sleep, so that they're in a different location and it's very highly active, intensive. They may never take the drug, but they know that they have it. So is this misuse? Is this dangerous? Is this bad? Well, you have to vote.
It's their preferred choice as a hypnotic, they're saying.
Well, we don't know why they take them, Joe. They just said they take them. Some of them might have taken them because they're going to fly on an airplane and they're anxious, so they take one on an airplane. The point is that us psychiatrists who should know about these drugs actually might take them unprescribed on an occasion. So is this misuse? Is this bad? You'd have to make that judgment yourself. I don't think it's bad, because there's no evidence that this leads to further taking and drug addiction. The second question that comes up is, if these drugs are sedative hypnotics, And like all sedative hypnotics, they work at the GABA chloride ionophore, and they can cause a physiologic dependence if taken on a regular basis over a period of time. So what do we know about that? If you take the drug at a prescribed dose, say you're taking Xanax 0.5 2 or 3 times a day, when will you really be dependent, and what is that dependence like? So the answer is, if you took it on a regular basis, within a few weeks, your receptor system will probably be modified to the degree that if you were to suddenly stop the pills, you might have some withdrawal symptoms. And then we can talk about what are the withdrawal symptoms and how bad are they. And in a simple way of thinking about it, depends on the dose and the duration. The more you've taken, the worse the withdrawal symptoms are, but they're never or rarely very severe unless you've taken very large amounts over a long period of time, which is usually not the standard prescribing. So if you look at the actual prescribing of therapeutic doses, the withdrawal symptoms are relatively mild and short-lived and are easily treated by just tapering instead of the patient stopping the drug quickly, you taper them off slowly over the course of a week or two. And the Brits actually have a tapering timetable, and it's reasonable. Now, there are some people who have trouble discontinuing a benzo. I think we ought to come back to that a little bit later. By and large, what we now know over 60 years is even in chronic use, these are safe and effective drugs. And there is no evidence of dose escalation. That is, once a patient who's taking drugs on a chronic basis is at the therapeutic dose, they tend to stay at the therapeutic dose, and it actually, over time, may actually decrease it a little bit. In other words,
tolerance is rare, you're saying?
I'm sorry?
You're saying tolerance or tachyphylaxis would be rare?
No, yes, I am saying that for anxiolytic purposes. For sleep purposes, there may be tachyphylaxis, and I'm not recommending these drugs right now for sleep. We're talking about their anxiolytic effects, the modal use of these drugs. Now, the drugs are clearly therapeutically effective. There's abundant data on that, and nobody will say that this is just placebo or bad luck, good luck or bad luck. These drugs work. And
that's part of the problem, isn't it? They have such a big effect size.
That's right. Exactly. They all work. They all work. So now the question is, are there competing drugs that also work so that people don't feel they have to take a benzodiazepine? And for acute anxiety, the answer is really no. That is, let me put it this way. If you, listener, psychiatrist, listening to this talk, are going to have a colonoscopy later this week, are you going to take an SSRI for your anxiety about the colonoscopy, or are you going to take a benzodiazepine or nothing? And if you go to the colonoscopy, what are they going to give you? Are they going to give you Prozac, or are they going to give you midazolam, or another, a little bit of lorazepam? In other words, for acute anxiety, short-term use of benzodiazepines should be standard of care, keeping the dose within reasonable range, and understanding that this is a person who is not taking other drugs that are also sedative hypnotics, or are people who are unreliable, and you can't be sure that they're going to take the drugs as prescribed. So if somebody is is in an acute stressful situation. Something bad has happened. They're really worried about something, family problems, illness problems. Short-term use of benzodiazepines at therapeutic doses are rational and reasonable and helpful. And then when the crisis is over, the patient can taper the drug off and stop. And if you look at that, the modal dose of benzodiazepine use by primary care physicians is about 3 weeks. Not chronic content.
Is the population that you're talking about the non-psychiatric population, the people without a known chronic anxiety disorder or a substance use disorder or liver disease? We're talking about the proverbial ideal patient for whom there are no contraindications.
Yes.
Because I would imagine, maybe this is where I'd imagine that's one of the sticking points for most prescribers is, how well do I know this person who's only going to use it for their colonoscopy?
Very good question. Very good question. So let's approach that. How do we do this in the office, in real life? Well, if we know the patient, if this is somebody we've known for a while, we have a sense of, are they trustworthy? Will they take it as prescribed, etc.? And that means knowing the patient and building a therapeutic alliance. But what if you don't know the patient? Okay? Patient comes in. This is a matter of clinical sensitivity and experience. I don't think there's any basic rules, but I think everybody would agree. The patient comes in and says, "Doc, I just moved to the city and the dog ate my prescription, or I lost my prescription, and so could I have Valium?" Red flag goes up. You say, "Well, wait a minute. Maybe we ought to talk a little bit more. Maybe you should come back next week and we'll talk some more." And the patient doesn't show up, you know that you probably identified a potential abuser. There's no I think official way of figuring that out, except for good clinical practice. Depends on doing a good interview with the patient, finding out why they might need a benzodiazepine. Have they taken it in the past? Is there a family history? What are your symptoms? And is this an acute crisis? Is this something chronic? There are people who, take benzodiazepines on a regular basis, and it's reasonable. And then there are people who take benzodiazepines on a regular basis. It's not reasonable. And because these drugs can have negative effects at high doses, we want to be very careful of that, as we would be with any sedative hypnotic.
And may I ask here about particular psychiatric diagnoses? We have folks coming to us in mental health who presumably have a psychiatric condition, which may be anxiety or may be coexisting with anxiety, but we certainly know there are certain conditions that arouse concern. The VA practice guidelines really frown on long-term benzo use and PTSD. The literature in borderline personality disorder tends to speak of a kind of a potential insatiable way to allay anxiety, and that's where the problems come in. Could you speak to some of those?
Sure. Okay, Joe. That's an excellent question, because that's all true. That there are populations of patients who are likely to be long-term users, and that might or might not be appropriate depending on individual patient. In my own opinion, and this is an opinion, not people can very much disagree with it, making a generalization about a class of people and whether or not they should take benzodiazepines is not warranted, because even within a class of people, veterans or personality disorders, even abusers, may actually benefit from an occasional benzodiazepine, and to restrict them and say, no, you can't have them, I think is not good practice. Again, this is my opinion. But what I've noticed in recent years, because everybody is so worried about benzodiazepines, that patients who should legitimately get a benzodiazepine are not given it. And doctors are made to feel guilty and actually worse if they prescribe benzodiazepines to people, when the general opinion is that should not be. And so there's data about this as well. I think in a talk like the one I'm giving right now, I'm trying to talk to the intelligent, sensitive clinician. Mm-hmm. Now, I will admit that there are lots of people who prescribe benzodiazepines who should not be prescribing them, or who are prescribing them ill-advisedly. And there's a lot of data about that. There are doctors who prescribe benzodiazepines to everybody, and to many people, ill-advisedly, and these people do become dependent on them, and I certainly don't approve of that.
Maybe this is about sizing up candidacy. The same way a surgeon will decide you are or are not a candidate for an aortic valve replacement. You are or are not a candidate for CPAP. You are or not a candidate for a benzo, and relative to what? I guess that's the other question: is what else you're going to use for long-term management of a chronic condition.
Right. Well, okay. So we can talk about what are the options for long-term use of benzos, and for what use might they be indicated, and compare them with other substances that might be used for long-term use. And if we're thinking about anxiety or anxiety spectrum disorders, DSM things, the two classes of drugs that are used for long-term use are benzos and antidepressants. And we have, fortunately, enough data to be able to guide us as to which would be preferred in general, although for any individual patient, the choice would still be a clinical one. So what do we know about long-term use? We know that both serotonergic antidepressants, the SSRIs, can be very useful for treating long-term chronic anxiety disorders. And anxiety disorders tend to be long-term and chronic. So this is a reasonable use of SSRIs. And the data would suggest that they are effective in most cases. What the data don't show, however, is what are the side effects of long-term use of SSRIs for people who are functioning in midlife and therefore have an active sexual life. And SSRIs have sexual side effects for a reasonable number of people. And so the benefit of the SSRI in such people might be tempered by the potential side effects. And there are other side effects of the SSRIs as well. Now, I'm not saying that this should eliminate the SSRIs. Like everybody else, I've prescribed them for long-term anxiety. But there is that potential problem. On the other hand, we have the benzodiazepines. And the benzodiazepines for long-term use have been very well studied. As I said, there's no dose escalation. And if this person is not a substance abuser and not an alcohol abuser, then the possibility that long-term benzodiazepines might be safe as well as effective. There are no head-to-head studies. Actually, it's not quite accurate. But overall, there are very few studies comparing the long-term use for anxiety by SSRIs versus benzodiazepines. There's one study with social anxiety done by Mark Pollack, a nice study, in which benzodiazepines were compared with SSRIs. And what it showed is that the benzodiazepines were more effective. The patients liked them more. And the other studies showed that the SSRIs were effective, but most people taking an SSRI for long-term anxiety disorder are also taking a benzodiazepine.
Yeah.
That
Or a plethora of things. I mean,
that's right.
many of
That's
our
right.
listeners have patients who are on a gabapentinoid, an SSRI, an atypical antipsychotic, hydroxyzine. I mean, for really difficult anxiety, we often have a boatload of things in the picture, right?
Right. So one of the things that I practice myself and try to teach our residents is to ask very carefully about alcohol, which is the primary issue with benzodiazepines, because they both work at the GABA chloride ionophore. So there's a severe drug interaction. And for somebody who's a heavy drinker, giving a benzodiazepine might not be the best idea. I would certainly consider trying something else first, as opposed to going straight ahead with a benzodiazepine.
That's a pretty lethal combo, isn't it? Too.
Excuse me?
Pretty lethal combo to mix and match your benzos with your vodka, isn't it?
That's correct. Benzodiazepines are not lethal in overdose, except when they're combined with other sedative hypnotics like alcohol. Then they are dangerous, and that should be clearly understood by the prescriber, and I would hope that they would be. Then, of course, if you think this patient is also using other substances of abuse, then benzodiazepines might not be a reasonable choice. I would like to say that, and maybe this is a good time to talk about benzodiazepine abuse. Benzodiazepines are abused. They're abused by substance abusers, alcohol abusers, and other opiate and cocaine and other street users. And there, of course, we want to be very careful not to provide these people with benzodiazepines. But I want to say that benzodiazepines by themselves are not abused for pleasure. You know, people don't go to Xanax parties Saturday night. Now, they may go to parties where Xanax is going to be used, but it's always in conjunction with something else. So the idea of abuse is real and serious. I don't mean to minimize it or make a joke about it, but by themselves, benzos are only abused by people who might be abusing them for personal reasons, feeling that they're not getting better, or they had hope that the benzodiazepine is going to fix their very disordered life or their very disordered personality or all the interpersonal problems that they have. You know, this drug will really fix it, and then it doesn't, so they take the.
Yeah, I bet you a fair number of our listeners are thinking about a patient right now who would fit that bill, where it's not simply to assuage psychic anxiety or somatic anxiety that's related to something like GAD or panic or social phobia, but something a little more, I don't know, existentially pervasive, someone who just can't seem to self-soothe, someone who's never acquired alternative means to be able to keep themselves intact. And so they know about the effect size of a benzo, and they want to take some time.
Listeners, pay attention to what Joe just said, okay? If there's one message that I think ought to get across, that's the message. That the people who shouldn't be taking benzodiazepines may be taking it in the hope that it will help straighten out a disordered life that otherwise they're having trouble with, and that there will be some magic in these pills. And it can be understandable. Some people's lives are in terrible shape, and they're not good candidates for psychotherapy, and they come for a pill. Example. I was talking with a young psychiatrist who lived in an area of Massachusetts where there weren't a lot of psychiatrists. So that the medical doctors were sending him all kinds of patients that they felt needed psychiatric care. And what many of these patients came in and complaining about is that they were so unhappy and so anxious that, could I please have my Klonopin? And that was a direct quote. These patients had heard or had experienced that somehow Klonopin was going to be helpful and was certainly going to help them sleep. And this poor doctor, this poor psychiatrist, he had patients coming in one after another asking for Klonopin or Xanax or something, and mostly Klonopin. And he asked me, he didn't think all these people needed it, but he didn't know how to say no. And these patients, when he tried to say no, would get very angry. And actually, he was threatened sometimes physically. So I suggested he put up a sign on his wall in the waiting room saying, "This doctor does not prescribe Klonopin for any reason." And to the person who answered the telephone to say, "Dr. So-and-so does not prescribe Klonopin." The next week, 50% of the people who had showed up disappeared. And the remaining people had legitimate reasons to take benzodiazepines.
But that other 50% is suffering and needs help of some kind. They may think help looks like a Xanax pill, but the psychiatrist or the other mental health evaluator might come in and say, I'm going to identify the nature of the problem you're having in a way that's a little different than you're identifying it. What you think is going to be helpful may not necessarily what I think could be helpful. You have to almost sort of sneak up on somebody to be able to say, I want to help you. I think you have a problem that I can help, but I don't know that what you envisioned is the answer.
Okay, so that's good psychiatric practice. That's what I would hope people have learned in their training and do themselves. Joe, I think you're spot on. That because, what I would add to that is you might say to the patient, I think I hear that you're really suffering, but maybe a second interview would be really helpful so we could really understand what might be best. Would you be willing to come back for a second interview? In other words, not prescribe the drug right off the bat. And my guess is people who are coming for the pill might not come back.
If they're shopping and they know what they want, and you're trying to treat them, but they just want the refill, that may filter out that population.
Yeah.
Can I ask, when I was in training, there was this term, tell me if you've heard it, it's unofficial, ego glue, this term? And when I was in training, antipsychotics were thought to maybe address, I'm going to use some old-fashioned language here, the lacunae in the minds of some people that just can't seem to bind their fundamental ontological anxiety together, and that maybe a dopamine blocker, for all its own problems, could help. I'm curious if you have an opinion about that.
I actually agree with that. I think that for some people, a low dose of an antipsychotic is the correct choice, not a benzodiazepine. That would not be somebody where I would be immediately thinking of. Now, I'd want to rule out, bipolarity, substance abuse, and maybe even personality disorder of the borderline type, because borderlines, or the kind of patients we sometimes think of as borderlines, can be substance abusers and benzo abusers. But for people who really quote get it together. They can't really perform normally. Their thoughts are erratic. Sometimes low dose of an antipsychotic can be very helpful, and aripiprazole is a very nice drug in low doses for that because it doesn't produce a lot of side effects.
And do you think a dopamine blocker actually even goes more directly to, let's say, the fight or flight limbic processes as opposed to the GABA system altogether? That is, fear-based hyperarousal might respond better to an anti-dopamine drug.
That's a very good question, Joe.
Speculate.
It's a really good question. I think I would look for other kinds of problems. I'd look for sleep and family history, but we just ran our big master class over the weekend, and this question came up a number of times, and all of our speakers agreed that one of the key pieces of information to help guide you in picking a class of medications is family history.
Mm-hmm.
Because suppose this person, well, I mean, I'll give you an actual example. And I was interviewing somebody, and I wasn't really sure what was going on with the patient. So I asked about anybody in the family have any troubles, and they said, no. And I said, well, is there anybody who doesn't sleep very much? So, who's up a lot at night? And he said, oh, you mean like Grandpa? Yeah, well, Grandpa's up always. He's always up at night chopping wood at 2 a.m. And I said, well, what about your sleep? Well, yeah, I don't sleep so much. I don't, I'm lucky. I don't need to sleep. And suddenly there was the bipolarity, which otherwise would have been missed.
If it were simple insomnia or primary insomnia, would you favor nowadays a benzo agonist like a Z drug over a benzo to spare the benzo's availability? Use that just for anxiety, but not for sleep.
I'm not a good person to ask about sleep and treating sleep. I can tell you what the sleep people say. And they say that the Z drugs are preferred over benzodiazepines because the GABA system has many subtypes and sub things, and the Z drugs tend to work on different subunits of the GABA system than the benzo agonists, and so they would recommend that, and they usually have the recommendation of not more than a couple of weeks of nightly use because the drugs lose their efficacy. But if you ask patients who take them every night, they say no, they don't lose efficacy at all. They're very helpful. But I can't. Don't quote me on that, and don't use me as a guideline for the Z drugs because I rarely prescribe them. I've never taken one, and so I don't really know the answer to that. I do think that the use of short half-life benzodiazepines like lorazepam are sometimes very helpful for sleep when people are in a state of arousal, namely crisis or illness. And we discussed this in the master class as well. The idea about a short half-life is that it's reasonably rapidly absorbed, lorazepam is, because it's highly lipid soluble, and there's no hangover when you wake up in the morning. It's not the most rapidly absorbed, however. Diazepam, Valium, is more rapidly absorbed, but Valium has a longer half-life. That longer half-life doesn't matter if you're only taking 1 or 2 nights pills. But if you're taking it on a regular basis, then the drug tends to accumulate, and pretty soon you have hangover and you're sedated during the day. So long half-life benzos are not recommended for that. Let me just make a little sales pitch here. At the beginning of this morning's discussion, I said we know the pharmacology of these drugs. That's one of the reasons benzos are very useful. The pharmacology of these drugs suggests that long half-life drugs have a problem if somebody is taking them acutely, because they get absorbed and they stay in the body longer, and so there are side effects that are produced longer. And the short half-life drugs don't have that problem. On the other hand, if you're taking a benzodiazepine for chronic suppression of your anxiety, long half-life drugs taken once a day might be actually safer and as effective. In either case, whether it's short or long half-life, if you're taking the drug daily or nightly for more than 3-4 weeks, probably the drug should be tapered off slowly when the patient wants to stop.
Yep. Excellent point. Two other things I want to ask you before we turn you loose. One is the American Society of Geriatrics, the Beer criteria, goes around fire and brimstone. The second you hit age 65, that's it, Buster. No more benzos for you. What do you have to say to the American Society of Geriatrics?
Funny you should ask. I might have an opinion about that.
I thought you might. I think you've written about this a little bit.
Okay. It's not an unreasonable suggestion that older people are more sensitive to sedative hypnotic drugs. So they will have a bigger effect at standard doses. And the solution is not to throw the drugs out, but to use lower doses. Clinical example. A colleague of mine says, "Can I ask you a question? My grandfather is, we think he's getting demented." First question, what's he taking? Well, turned out he was taking Valium. Oh, how much Valium is he taking? He's taking Valium 5 milligrams 3 times a day. I said, all right, let's slowly lower the dose of the Valium and then maybe even change it or stop it entirely. And of course, he wasn't getting demented, and as the drug was discontinued, he kind of woke up. So there's no question that at the usual adult therapeutic doses, elderly people might have more side effects, and some of those side effects might look like they are getting demented and causing Alzheimer's disease or something like that. Or they're sleeping too much and then they're up at night, in which case somebody gives them another pill and just makes it worse. Or they're more likely to fall, which is true.
Which spooks all the primary care doctors, right?
Okay. Well, I'll come back to the falls in a minute because I think it's very important. Also, if they're still driving a car, they are more dangerous. And one of the jokes that people in Florida talk about is you want to be not driving your car around 5 to 6 o'clock in the afternoon, because that's when the old people go out for the early bird dinners, and they're driving cars and they're going to smash into you. And I don't know whether that's true or not, but that's what you hear. All right, so what actually do we know about this? Yes, benzodiazepines, long half-life and short half-life, may increase the risk of falls. if you look at the risk of falls with antidepressants or antipsychotic drugs at therapeutic doses, the risk is greater than with benzodiazepine. Not much, but it's more to the point that it's not just benzodiazepines, it's any psychiatric medication, but benzodiazepines among them. And it's certainly true that long half-life drugs probably are not a good idea for older people because their metabolism is slower, and therefore the drugs last longer in the body and they accumulate, and then the older person is unsteady, more likely to fall. Older people also sometimes have a cocktail at night, or schnapps or something, and if they're taking a benzodiazepine and alcohol at the same time, they are at risk. So it depends on the patient, depends on the older person, depends on where they're living, and but it's not automatic that the drugs are bad for those reasons. But they certainly are risky for those reasons, and we should pay attention to them.
Then they should do a falls risk, right? They should say, "Are you a candidate? Have you fallen? Have you broken a hip? Do you
exactly.
do you fly a helicopter? What are your personal risks?"
Okay. Second point, do benzos cause Alzheimer's disease? The study which suggested it was a very good study out of Columbia, and what it showed, it was a study of drug use, not of patients. No patients were actually seen in this study. But what they found in this study was that older people who were taking drugs for Alzheimer's disease, like Aricept, were also likely to be taking a benzodiazepine. And when they compared the control group, people who were not taking the drugs for Alzheimer's disease weren't taking benzodiazepines. And so the conclusion was there was an association between the two. The problem was that association was then interpreted as the benzos caused the dementia. Now, they tried to control for that by trying to see how many years before the dementia diagnosis was made were the benzos taken. But the main point was that some people, when they think they're getting demented, get more anxious and start to take a benzo. So it could be the other way around. It's not that the drug's causing the Alzheimer's, it's the Alzheimer's causing the drug.
Airbags cause car accidents, right?
Or for some other reason. So since that time, several studies have been shown that clearly, in controlled research studies, that benzodiazepines do not cause Alzheimer's disease.
The term protopathic bias is something our viewers may or may not know about, but this is this very idea that the ailment of interest, whether it's dementia or cancer or anything, you might get a prescription for something along the way as a marker of your inevitable, inexorable course toward that ailment, and it's not a causal phenomenon. In fact, it's like saying cigarette lighters cause lung cancer. Well, they don't, but the people that are on the course for lung cancer from another reason are probably more prone to have this as an artifact. You're saying benzos, by and large, would be an artifact.
Yes, but there is a point to that study, which I saw in my own research. Because I was doing some research in a very high quality nursing home in the Boston area, and we were looking at benzodiazepine use in the elderly, and the question came up is did the benzodiazepine affect cognition, memory primarily? Well, we couldn't actually give people benzodiazepines and unless they were really needed, and we couldn't use placebo, but we could ask people, some of the residents, would they be willing to taper and stop their benzodiazepines and see how it affected their memory. And it took us 3 years, but we got a small group of people who were willing to taper and they were mostly taking Ativan, lorazepam. And so they slowly tapered, and we tested their memory before and then after 3 weeks after they had stopped. I mean, this isn't a very fancy study, but it was very interesting. So at the end of the 3 weeks, they were tested, and indeed, when we did a Wechsler memory testing, the people who had discontinued the drugs had a marked improvement in their Wechsler memory compared to those who stayed on the drug. It was huge. You didn't need statistics to see the difference. So I thought, well, all right, so I sat down to have lunch with these people the next day after we had analyzed the data. These nice people, and I said to them, the people who had discontinued and now had better memory, I said, aren't you glad we got rid of those terrible drugs and you have a better memory? And they said, no. I said, what? What do you mean? They said, well, it's true that we can remember things a little bit better, but the kind of things that we were forgetting was like, what did we watch on television the night before? And if you're asking me, would we prefer to feel less anxious, sleep better, and have worse memory than have better memory but still feel anxious during the day and maybe not sleep so well? We'll take the memory loss anytime, because what's to remember? I mean, we can remember our grandchildren's names, we remember our wedding date, we remember all things in the past. The memory impairment is recently acquired information. It's an anterograde amnesia. And when you ask people what they don't remember things that they recently experienced or learned. Like they meet you and then they will say to you, I might not remember your name the next day. And that's not necessarily dementia, but it is made worse by a benzodiazepine. Benzodiazepines will affect recent recall. And it depends on the dose, and it depends on the age of the patient, and depends on their memory in general. But they don't cause a dementing illness that goes on. And as we saw many times, and in the study, if you stop the benzodiazepine, the recall is normalized. But the patient doesn't want that. The elderly person would prefer to stay on the benzodiazepine. No, not everybody.
I guess as long as they're not forgetting whether they left the stove on or locked the door.
That's right.
Left the car running with the keys in it.
That's right. That doesn't really happen.
Wow.
Now, these were low doses of lorazepam in a nursing home. So I want to emphasize that anxiety in the elderly is very common, particularly in the very elderly, because their health is not, is threatened, thinking about death, thinking about all the losses that they've had, the movement, I'm getting into that age. I know it's a very anxiety-provoking age. And sometimes relief of that anxiety is very, very helpful. So when you ask older people what they would like, sometimes they would like a little bit of help. Now, it doesn't have to be a benzodiazepine. There are other ways of helping older people. And if you go to good nursing homes or these senior residence facilities, there are lots of good activities. And sometimes there's a sherry hour at 5 o'clock in the afternoon, which is very reasonable for people who are used to drinking but don't want to really drink now. But a little bit of alcohol sometimes just hits the spot.
And you sure wouldn't want to miss an older adult depression by treating it only with the benzo. If someone's anhedonic and it's not just the existential, what is my legacy, but rather I don't want to get up in the morning and I have no reason to.
So let me say, Joe, because I know we're getting near the end.
Yeah, we should.
How I would see it. I don't think prescribing benzodiazepines to elderly people is a great idea unless I think it's really going to be helpful. So I'm very careful about that. I limit the use to lorazepam by and large. Oxazepam, Cirax, is also a short half-life benzo that's very good, but it's not rapidly absorbed the way lorazepam is. I make sure that this person is not taking other sedative hypnotics or alcohol is a problem. I try to combine this with a discussion with the patient and maybe some psychotherapy, short-term psychotherapy about what's really upsetting and why are they anxious, and are there other ways of dealing with this besides taking a pill.
I'm here to help.
For those people who really need to take long-term use, I make very sure that the people who are giving them the pills keep the doses low and supervise the taking of the benzodiazepine and have the physician who's in charge follow the patient reasonably closely so that this is not just ongoing benzo use.
Nothing in a vacuum.
And I think it's fine.
Yeah. Well, Carl, I really want to thank you so much for sharing your vast wealth of knowledge, your wisdom, your experience, the years that you've really dedicated to thinking about and studying these kinds of problems and questions that I'm sure many of our viewers and listeners wrestle with day in and day out, whether you're aware of it or not. We've hopefully made it more mindfully front of consciousness.
Yeah, I think that I would. Again, I think you're spot on. These drugs are okay when used appropriately, and when they're not used appropriately, they're not okay. And it's clinical wisdom and care, and sometimes a little bit of psychotherapy can go a long way to. So rather than just automatically using a pill.
Indeed. I'm going to coin a term: mindful prescribing. How's that?
Oh, love it.
You can borrow it. All right. I want to thank you again so much for joining us, Carl. I want to thank all our viewers.